Awesome. Thank you, McKenna, for that wonderful introduction. I'm going to share my screen and here we go. Share sound, share. There we go. All right. Can everyone see? Okay, perfect. Okay, so hello everyone. My name is Eddie Hackler III. I am currently a cardiology fellow. I'm going to go through a PowerPoint that I made for you all to kind of give you a visual. Since we're here on Zoom, I wanted to give you all something to look at. So I promise you it won't be like a lecture, so I hope not to bore you all, but just some visual context to what I'll be talking about, okay? All right. So I wanted to start off by talking about my journey. So I, you know, like everyone else, I graduated from high school and I went on to Bowling Green State University. And I took a major in Bachelor of Science, which is what my degree is in. And a lot of people who are interested in the medical field or any type of health field um, always ask me what's my major and what they should be doing. And one thing that I always want to emphasize to people that I did not know is that you don't have to be a science major to go into any healthcare field. I think it helps in certain ways, but if there is something else that you're interested in or another major that you started off with, you don't necessarily need to switch or need to feel like you have to be a science major. Most colleges have what we call a pre-med track, which is not a major, but a track that you take certain courses. So biology, chemistry, or organic chemistry. And as long as you have those prerequisites, specifically for medical school, then you can be admitted into a medical school not having had a science background or science be your major. Also, a good tip from that standpoint is that a lot of people applying to medical school are science majors. So if you have a major that is not science background, it's a way for you to stand out. Okay. Um, Other things. So while I was in college, I did a lot of extracurricular activities. Here in the right side, I joined a fraternity. Oh, let me get this out the way. Sorry. I joined a fraternity, and I also did a lot of other different extracurricular activities. And another thing that I did when I was in popping up. Another thing I did when I was in undergrad is I did research. So I did a research program for summer in New York City. I was at Albert Einstein College of Medicine. And here I was able to meet people who were also in undergrad studying for the MCAT and wanting to pursue medicine as a career. So I won't get into the nitty gritty of my research, but at the end of the research period, which was the summer, so I had 3 months, we had a poster ceremony and I had a presentation that I gave. And I think to this day, this same poster and this same experience I have on my resume. So although this was probably well over 10 years ago, it's still something that I talk about even at this stage that I am now. I think this was a very important opportunity because it allowed me to see, just how, from a science standpoint, how research is involved in the field of medicine. So I think, I have an advice part of the talk, but I'll be just dropping little advice tips as long as I go. I think it flows better. But one thing I want to say about research is that a lot of people think that you have to have research to go to medical school, and you don't. However, I think it helps, and it definitely helps you stand out when it comes to all the applicants that are applying. And it's always just a good foundation to have going into medical school. Okay. Also, I did a lot of different shadowing experiences where I got to I shadowed a pulmonologist, I shadowed a dentist before I did a lot of different shadowing just so I could see exactly what it's like being a physician. And last but not least, my journey during my undergraduate days was my MCAT prep. So anyone who's going to med school probably knows much about the MCAT, and it's a brutal test, but it's a test that is very much doable. And once you get past it, you never have to think about it again. And what I did was I took a Kaplan course and I took a Princeton review course. So both of those courses I ended up taking. I personally, for my learning style, I enjoyed the Princeton review a little more. I'm not sponsored by Princeton Review or anything at all, but I did enjoy their course just for my own learning style. And I would recommend anybody who's serious about taking the MCAT, at least look into a Kaplan or a Princeton Review course. So once I finally got into medical school, or at least towards my medical school career, I first did a post-baccalaureate program. And so once I graduated from Bowling Green, I did a post-baccalaureate program, which basically it's a program where you take courses, and it's geared towards people who may not have good grades, or people who may not have done well on their MCAT. And that was me for the first time. The first time I took my MCAT, I didn't do well. So I applied and I got into this post-baccalaureate program. So it was a 1-year long program where I took courses similar to the courses that you take in undergraduate. So biochem, anatomy, and physiology. And we also took some med school courses as well. And I also retook the MCAT during that year. So the goal was that I would do better, or I would do well in these courses, gain some more knowledge, retake the MCAT, get a better score. And if I did get a better score, then I would be admitted into the medical school. And fortunately, that's exactly what happened. I retook the MCAT. I did way better the second time that I took it, and I was offered a spot into the upcoming class. So as you see here to the right, this is my medical school class, the people that I graduated with. I spent 4 years studying beyond measure. And I want to just go through kind of like what medical school is from a general standpoint. So our first year, we took basic science courses in this classrooms where we took most of our courses actually. So you take biochem, you take anatomy and physiology, and you take statistics and things of that nature. And then once you finish that year, you go into your second year. And our second year was, we broke up into organ systems. So we would have blocks and we would focus on whatever that organ system was at that time. So if it was, we would focus on the heart for about a month. We would do the physiology, the pathology, and then and then the pharmacology. So, how everything works, what happens when things aren't working right, and how do you treat those things, okay? So we did that for every organ system you can think of, from neurology to pulmonology to cardiology, all the way into gynecology, everything else. And then our third year is kind of like a transition from your first 2 years, is when you start your hospital rotations. So we started to rotate in the hospital in the different subspecialties. And at this point, you start to actually feel like a doctor, because now you have a white coat and it's a short white coat with a white coat nonetheless. And you are on teams with residents and attendings, and you're seeing patients. And this is the part where I felt like was very enriching, because you got to see exactly where you may see yourself fitting in the world of medicine. And year 4, you're still doing hospital rotations, but not as many. Your main goal for your year 4 is trying to find a job. So matching and match day and getting a residency spot, that is the main goal for the 4th year. And a lot of people do different things to try to secure that. And it's a really fun year. It's probably my funnest year in medical school was my 4th year. Okay. So moving forward, so eventually, after graduating from medical school, I then matched into a residency program. So I attended residency at University of Texas Southwestern. We call it UT Southwestern. It's in Dallas, Texas. And one of the fun facts about the hospital that I actually was working with in residency was that it's the place where JFK, after he was assassinated, the hospital that he was taken to right after. But Residency, I'm not sure how many of you all watch Grey's Anatomy or are familiar with the show, but it's work, work, work. Residency is now your first job after becoming a doctor. And here on the left, you see this is probably like my first or second day of residency. I was so happy. And during residency, I did a lot of neat, cool things. One of the major things that I did was research, and I worked on a research project with one of our cardiologists, and I wrote a paper that was then published in the American Heart Association journal. And if you look here in the up right hand corner, I was at a residence poster competition, and I've gotten to talk about this work that I've done, and I've done a lot of different oral talks about the research that I've done. And even to this day, I still talk about the research that I've done. So one theme that I wanted to let you all know is that everything that you do, even starting from now, if you're just getting into college, or if you're still in high school, or if you're already in college and you're graduating, everything that you do, you start like you start a resume. Essentially, you start a paper trail of things that you do, that things that you can talk about. So never think that it's like, oh, I have time. The time is now, and it's always now. So always remember that. So whatever you're doing, give it your all, give it your hardest work, and just remember that 10 years down the line, you may still be talking about those same things that you're doing now. um right here in this picture, when I'm holding the stethoscope with the young gentleman, I did a global health elective during residency. And what that was that was one of my electives, which was a month long. I got to go to South Africa, Cape Town specifically, and I worked in their hospital as a physician there. And it was very rewarding. It was a very eye-opening experience just to see a health system very different from the American health system, and to treat a patient population that was very different than the American population that I was used to treating. So that was something that I did that I thought was very eye-opening. I know a lot of people can study abroad during college, or may have opportunities if you are already in like medical school, or if you're in residency, to go and do medical mission trips, which I've done that as well. I got to do that when I was in medical school. I went to Ghana, and I worked in the OBGYN floor for about 10 days. So that was eye-opening as well. So um, residency is work, 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 and research, and a little bit of global health elective if your program allows you to do so. Okay. So now we're going to move in to fellowship, is what we're here to talk about, really. So I matched at Case Western Reserve University here in Cleveland, Ohio, which is attached to University Hospitals. And this is where I'm completing my fellowship now, and I'm currently a second year, going to be a third year starting July 1st, and our fellowship is 3 years. So just a shy of a year, and I'll be done with the fellowship. Oh, sorry. Okay. So what it's like to be a cardiology fellow. I think I wanted to start with the echocardiogram. So a cardiology fellow, basically what it means is you are training to be a cardiologist. So it's different from residency, where you're just training to be a doctor. A fellowship is an option that you have after graduating residency, where you can either go be an attending and start working, or you can get more training. So fellowship is like a second residency, something a little more specific. Okay. So as a cardiology fellow, my main job is to treat people with heart disease in the hospital. Okay. And one way that I'm able to do that is with this tool called the echocardiogram. So the echocardiogram is an ultrasound, which is basically sound waves. And you use the ultrasound to produce images of the heart, so we can see the function of the heart. And here in this diagram, the upright, you see the ultrasound being placed on the chest, and you see that the ultrasound waves are going towards the heart. So then, oh, I'm sorry, I'm gonna go back, to then give you images that you see on the screen. So if you look here in the upper left, the gentleman here holding the probe to the patient's chest, and then also looking at images on the screen while he's doing that. And on the bottom right, you see the type of images that you would see when you do this type of imaging modality. So here I won't go through all the nitty gritty, but this is, you have your left ventricle, which is the main pumping chamber of the heart, the right ventricle, which sends deoxygenated blood to your lungs. And here you have your left atrium, and here is your aorta, and this is the aortic valve. And then oxygenated blood goes from, I keep doing this, sorry. Oxygenated blood goes from the left ventricle into the aorta to the rest of your body. Okay. So there's two types of echocardiograms. There's a transthoracic, which is he's doing right now. And basically transthoracic just means you're going on the thorax, so the chest, to produce these images. The next type of echocardiogram is called a transesophageal echocardiogram. So this one is a minimally invasive procedure where we take a probe, which you see here, that has basically a camera on the end of it that produces ultrasound waves. And we take this probe and we go transesophagally into the patient's esophagus. And the point of doing that is that the esophagus sits right behind the heart. So if you can get down to the level of the heart, you're able to produce images through ultrasound that you can see. And if on the bottom right-hand corner, you can see here, these are the type of images that we will produce with a transesophageal echocardiogram. So again, here's that left ventricle was the main pumping chamber, the left atrium that receives oxygenated blood from the lungs, the right ventricle that then sends blood that's deoxygenated to the lungs, and the right atrium tricuspid valve. Okay. So typically people, we do this for, a number of reasons, but one main reason is someone who may have a disease called atrial fibrillation, which is arrhythmia of the heart, where the heart's not pumping correctly because there is fibrillation at the top chambers. So the heart basically is not getting a full cardiac output that it can. And what's important in that scenario is that their blood just pools in the top left atrium up here, and it can cause blood clots. So before you treat someone who you want to see if they have a blood clot, because you can't shock the heart out into a normal rhythm or give them medication that can put them into a normal rhythm without knowing if they have a clot or not. Because if they do have a clot, that can embolize to the brain and cause a stroke. So this is one procedure that we do all the time for that indication. And as you can see, the doctor here putting the probe in the patient's esophagus and holding the probe wand and looking at an echocardiogram to look at these pictures that we have here on the right. Okay. So the echocardiogram is like the bread and butter of cardiology. As a cardiology fellow, it's like my best friend. It's like my own video game. These machines cost thousands and thousands of dollars. So I get to play with basically very expensive toys every day. Okay, another big area of cardiology is called the catheterization lab, or we call it the cath lab for short. So this is another minimally invasive procedure that we diagnose and treat certain diseases with. Notably, like people who have heart attacks, this is where they go. So people, have chest pain or, a lot of shortness of breath, and we're thinking that, they may have a heart attack on there because of an EKG they may have gotten. We send them here to the cath lab, and you notice that these gentlemen have on gowns, hats, masks, and gloves, because it's a sterile procedure, meaning that this is a procedure that you want to be extremely, extremely clean. So you have to wear certain materials so that you don't cause infection or you put the patient at risk for infection, because you'll be doing a lot of things that can then lead to that. You'll be going into an artery, into someone's bloodstream, and infection can cause that way. So you have people who are dressed up in sterile garments. The patient down here on the right, you can't see them, but they're draped as well with this sterile drape to keep this sterile. And you can see it better up here in the left upper hand corner. The gentleman is looking at the screen, which to the right and to the left, you have what he would be looking at. Okay. So basically this is a coronary angiogram, which basically means we're just looking at the vessels that supply the heart. So the vessels that give blood to the heart. So you have three main vessels most of the time. Sometimes you can have four, but most time it's three. This is up here. This is your right coronary artery that supplies the right side of the heart and the inferior portion of the heart. And then down here you have the left-sided heart, the left-sided arteries that supply the left side of the heart. So you have the LAD, which supplies the anterior portion of the heart, and then you have your left circumflex down here, which supplies the lateral portion of your heart. Okay, and this is a place where we do a lot of other procedures as well. But I wanted to give you an example of what it may look like when someone has a heart attack. We hear, but what does that really mean? So basically, it means that someone is not getting adequate blood flow to the heart. So when muscle doesn't get the oxygen that it needs from the blood, it dies essentially, and that's what causes pain. So if you look here on the left side, you see how this artery then becomes very, 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 very narrow. And down here is the rest of the vessel. So if someone was complaining of chest pain and we do a cardiac catheterization and we see this, we see, oh, okay, well, this is what's causing that pain. It's decreased blood flow on the right side. So we can fix that. So we have things they are called stents. And I tell people all the time, a stent is like a slinky. And what it does is it will hold the vessel open so then blood can flow normally to the rest of the artery and then supply blood to the heart that wasn't getting blood before. Okay, so again, here this is a depiction of what we've seen. So right here is the right coronary artery, which again is supplying the right side of the heart and the inferior part of the heart, and that's what this vessel up here is. And then on the left, you have the circumflex and the LAD as well. Okay. Okay, so imaging is a huge part of cardiology as well. We have a lot of different imaging modalities, and as a cardiology fellow, it's important that you have a good handle on all these different modalities, which I'll talk briefly about. So a lot of people may have heard of a stress test. So we have different ways of having people undergo stress tests. One way is we call it a nuclear stress test, and during this test, you use nuclear isotopes to kind of depict where blood may be flowing, where blood may not be flowing in different sections of the heart that may indicate that they may have a blockage, like we've just seen in the previous slide. Okay. And if someone did have a nuclear stress test and it was concerning for a blockage, you would then send them to the cath lab to then have a look at their arteries in real time to see if there's anything that we need to fix. Okay. Up here to the right, this is a cardiac MRI, an MRI of the heart essentially. And this is probably the most sensitive test that we have looking at the heart from a functionality standpoint. And here, it looks very similar to the echo, just a little different, but you have your left ventricle, your right atrium, and your left atrium. And we use this for a lot of different reasons as well. Down here at the bottom right, this is what we call a cardiac CT or coronary CT. This is a modality that we use to look at the arteries of the heart under CAT scan. And if we see any calcium or anything in the vessels and it's the right scenario, we'll send the patient to the cath lab as well. So all of these tests are all done just to say, okay, do we need to send this person to the cath lab so we can take a look at their arteries or not? So as a cardiology fellow, these are things that you have to learn and you have to have a good grasp and handle with, and in order to diagnose certain diseases. Okay, of course, we have the cardiac ICU and the wards. So we call this rounding. And basically what rounding is when you go with the attending and the team of residents and maybe medical students too, and you go and you see the patients who are on your team that you're taking care of. And there's usually one person that's responsible, either like the resident or the medical student, that's responsible for presenting the information to me, the fellow. As you can see here, up and right here, some of my residents are presenting to me on rounds, our patients, or you'll have a medical student as well. If the medical student is on the rounds, they will be presenting the information to the patient and basically, well, to the physician. And essentially, they're giving, updates about the patient that may have happened overnight. Also, we're talking about the different labs. We're talking about the different imaging modalities that they've gotten, like all the things that we talked about. What did the echo show? Or what did the nuclear stress test show? Or what did the CT for this gentleman show? Or what did the cardiac MRI for this lady show? So all that information that we use, we gather it, and then we use that information to then make decisions. So also down here at the bottom of the left-hand corner, sometimes we have to do procedures for our patients at bedside. So this is me placing what I call a swan at the bedside to help out a gentleman who's having heart failure. And we use that information from the swan to make decisions as well. So all these different things happen while you're on the wards or if you're in the cardiac ICU. And we use that we use this time to kind of make decisions for our patients and create plans on how we're going to treat the patient. Okay, so that's the general life of a cardiology fellow. We round, we do echoes, we learn all these different image modalities. We're in the cath lab. We're teaching medical students, we're teaching residents, we're overseeing all these different people to kind of help make decisions for our patients. And as a fellow, I'm not the boss. We have an attending who is the boss. I'm just the right-hand man, essentially. And that is the difference between a fellow and attending. Attending is the final say in all of this, and I come right under. So some advice that I would love to give and that I always give. One, find your village. It doesn't matter what you're going into, whether it's medicine or not. You need to find people who love you and people who are going to support you and people who are going to push you forward. Because there will be many times where you're definitely going to need their support. So find your village is so important, and it can be your family, it can be your friends, it can be your teachers, it can be your coaches, whoever that looks like for you. Find them. For me, it's my family, and they have been with me since day one, and they always support me. And I always know that if there's something wrong, I can turn to anyone in my family and they can help me. And that's so important when you're going through something that's so strenuous. Another bit of advice is I say seek mentors. This is something that I think is very important. You need to find people who are doing what you want to do, and seek them out and pick their brains. There's so many people out here who have so much wisdom, and they're just ready to give it. We just have to go and seek them out. And all your mentors can be different things or do different things and be different people. I had 3 of my mentors that have helped me out tremendously. They all are very different people and all do very different things, but very, very incredible people who have helped me out along the way and continue to help me out to this day. So find people who are doing what you want to do, and then pick their brains. The best mistakes to make are actually not mistakes that you have to make, but the mistakes of other people. They'll tell you, oh, okay, this is what I did, this is why it didn't work for me, or this is what I did and this did work for me. And you would be surprised at how much that helps just along this journey when you have people who have been where you want to be and who can help guide you along the way. Okay. Also, another bit of advice, remember your why. I think this is very important. It's because like I said before, a lot of times you are going to be just, second guessing yourself, feeling like you don't belong or feeling like you don't want to do anything anymore. And I feel like in medicine in general, specifically, that could be very, very cumbersome, and it could weigh on you a lot. But I always tell people, remember their why. Remember why you started. Remember who you're doing this for. And for me, I wanted to become a doctor because I wanted to help people. And also, I am the oldest of all my siblings and all my cousins, and I always wanted to give them a positive example and a role model to look up to. So those moments where I felt like I didn't want to do this anymore, I had to remember, okay, well, look at everyone who's watching me. I have to be a great example for them. And then also, I said I wanted to do this to help people, and that's exactly what I want to do it for. So I just had to remember that, whatever I'm going through at this time is temporary, and that I need to move forward. And once I move forward, that, I'll look back and like, wow, I really did make it through. Okay. And some other advice that I love to give to people is to take the MCAT seriously and retake it if you must. Like I told you before, I took it twice. The first time I took the MCAT, I did not do well. And I retook the test and I did so much better. And I prepared for that, I think, so much better the second time around. And if you don't do well on the MCAT the first time, and it's okay, take it again. If you don't do well the second time, take it again. But each time you take it, try to look back and see, okay, what did I do? What didn't I do right? What can I do differently this second time around? Okay. Also, personal statements. Have someone review your personal statement. It may take several revisions before it's perfect, and that's okay. But have someone who, for me, I had at the time, I think I had actually a resident look at my personal statement, who sat on the admissions committee, and we kind of went through my personal statement until I got a personal statement and an outline that looked really good, and then I actually fleshed it out with the details. And it was something that I was proud of after about 3 weeks of just working hard on it. Okay. But yes, have someone review your personal statement. You will thank yourself so much in the future for that. Also, apply broadly, if you're able to. And what I mean by that is, don't just apply to the medical school, that's in your city. Apply to the medical school that's, 2 states away or across the country, or somewhere that you wouldn't necessarily think about going. And I say that because medical school is so competitive, and there are more people applying than there are available spots. So if you apply broadly, you increase your chances of actually matriculating into a medical class. And also, you just be open-minded to places that you've never thought about before. Okay. Participate in extracurricular activities. Whatever it is that you like to do, whether that's sports, whether that is sororities, fraternities, whether that's any type of club or anything that you want to do it, and talk about it. Let people know that you're doing those things. Most medical schools, they look for applicants who are well-rounded. They want you to be smart, but they also want to know that that you can do other things as well. That makes a great applicant, and eventually great doctors. And lastly, but definitely not least, you have to believe that you're already a doctor. You have to live it, you have to breathe it, you have to believe it, and you have to watch it manifest. When I was in undergrad, I think I think Twitter was a big thing back then, and my Twitter name was Dr. Hack06, and I wasn't even a doctor yet, hadn't even gotten into medical school yet, but it was something that I was kind of cultivating for myself. And even growing up, my family always referred to me as Dr. Eddie, and would tell people that I was actually a doctor when I wasn't even a doctor, which, whatever. But that support and just that mindset that I am already what I am trying to be, it's just a different way of living life, and it puts you on the right path. And I think that it's imperative that we know that we belong and that we are worthy of these things. You get in life what you're willing to work for. Okay. All right. And I will take questions now.
So there's already a couple of questions in the chat that I'll go and read off. And for everybody else, feel free to put them in the chat, or you guys can unmute. Just make sure we're doing it one at a time. So the first question we got is from Sydney, and they asked, what is your learning style? What made Princeton Review the best course for you? So what did it entail, and what kind of made it stand out over Kaplan?
So a great question, Sydney. For me, I'm big on applications or applying knowledge. Princeton Review, they had a big science workbook. I'll never forget because I spent so many hours by it. But it was a big white science book that had probably 1,000 different questions. And I just went through those questions. And by the time I got to the end of the book, I realized that I had learned so much information just from applying it. Like, I think the first time I took the MCAT, I did a lot of reading. I didn't do a lot of different questions and like practice applying the information that I was learning. And that was something that I felt like was very beneficial for me, was learning how to apply the information, because what you're doing, you're taking a test, you're going to be asking questions. So just reading the information is not enough. You have to know how to apply what you're learning. And I think Princeton Review did a good job at that time of providing that for me. They provided just way more opportunities for me to practice applying the information that I was being taught. That was a great question.
That was a good question. Carla asked, are you required to do research as a resident?
Carla, no, you actually are not required to do research as a resident. For me, I wanted to do a subspecialty, cardiology, which is actually very competitive. So it makes you stand out more if you've done research. And I have done significantly less research than a lot of my peers. So I'm probably one of the people who probably didn't even have research on my resume when I actually applied for my fellowship. It was during the interview process that I actually finally got published. So, I mean, I had research experiences, but I didn't have publishing. And I think that's something that I should probably say a little bit about more, is that it's great to do research. I think, but you need to, if you're doing it, you should always be seeking to publish. And what I say when I say that is submitting your research, writing it up, submitting it to journals, and having journals accepted into their actual journals. That's what people really, really care about, is, okay, how much have you published? Because it's a show of your productivity. And it shows that, okay, you started doing something, you completed it, and you finished. So, yeah.
That makes total sense. Another question came in that I was actually wondering too, and it says, why did you choose cardiology, and did you want to do another specialty before you landed on cardiology? So what kind of drove you to this path?
Yeah. So it's actually when I was in medical school that I decided on cardiology. Prior to that, I thought I wanted to be an oncologist, which is a cancer doctor, and I quickly learned no, that was not for me. And I think after that, I was leaning towards anesthesiology. But what kind of landed me on cardiology was during my medical school, I did some community service, and I was going to barbershops, talking to men about health. And a lot of things that I learned during that was that a lot of men, specifically it was Black men in these barbershops, that were afflicted by hypertension or high blood pressure. And I then learned that most people in the world are going to die from cardiovascular disease. That is the number one killer in the world. So for me, I felt like, okay, well, if I become a cardiologist, I can do the most good for the most people, since this is the number one killer of people worldwide. And once I had that in my mind, I stuck with it, and my plan never changed. And to this day, I think I made the right decision.
Awesome. I have a question. So you talked about, like, you did a little global health studies and you traveled to certain places. Do you have a favorite place that you went?
Oh, yes. Cape Town, South Africa is by far the best place I've been so far. The people there were just amazing. They were very welcoming. It was nothing like you hear on TV. And I think I bonded so much with so many different people that it made it a very enriching experience for me. And like I said, being there and treating people with a lot of different diseases that we don't necessarily see every day here in America, that was amazing as well. And then just beyond the scope of medicine, like Cape Town was a beautiful place, great like landscape, very outdoorsy place, great food. They had a safari where you could see all the like wildlife animals. Like I felt like I was in Jurassic Park at one point, and it was just very very eye opening. So that's definitely my favorite place so far. I have other places that I want to visit, but so far Cape Town has the time.
Um, Another question just came through and it asks, during your medical school interview, did admissions differentiate since you had done a post-bac?
um, I think for me specifically, the medical school that I went to, the post baccalaureate program, it was a conditional acceptance when I started. So I knew that if I basically did what they expected me to do, that I would be able to matriculate into the class. Um, so I think yes, but also there are a lot of post-bac programs don't have that conditional acceptance. So people who I've known who've done post-baccalaureate programs who then apply for interest into medical school at other places, I know it's something that they're interested in at least discussing and talking about. They'll probably want to know, okay, well, why did you do the post-baccalaureate program? Did you feel like it helped you? And they're also going to be looking at your test scores and your grades to see if there was any type of increase after doing that.
Rachel just asked, when you were in med school or at any point before fellowship, were health disparities ever a topic of discussion through lectures/meetings?
To be honest, not really. Um, I mean, I went to a medical school that their mission was to serve the underserved population, which it's not every single medical school. So I think I knew a little bit more about it because of the medical school that I went to, but in the general core of my medical school training, I don't feel like it was something that was talked about enough, especially with the amount of disparities that we see. And I can't speak for other medical schools, but my inclination would be that it's probably not something that is ingrained in the medical school curriculum. To a certain extent, it may be, but I don't think that is talked about enough for what we see.
Those are all really good questions, guys.
Yes, keep the questions coming, please. Pick my brain.
I have a question. After your fellowship is over, do you already have a plan pretty much set up? Are you planning to just stay at the hospital you're at, or what's your plan for the future look like as of right now? And how do you go about setting that up when you're a fellow?
Oh no, that's a very great question. I'm working on that now. I think most people, once they leave fellowship, they tend to stay at the hospital that they trained at, statistically speaking. For me, I'm in Cleveland, Ohio. I was born and raised here. I love it here. However, after being in Texas for so long, I am spoiled with by weather. So I like good weather, and that's warm weather most of the year. So I want to go somewhere where the weather is a little better, less snow, no snow preferably. So I'm thinking probably Georgia, maybe Texas. Those are the places that I'm looking at. And what you do is you basically, your CV, which is your resume. you get that together, and you send that to different places that may be hiring physicians in those places that you want to go. So just basically just applying for a job just like anyone else would. And even if I wanted to stay at my hospital, I would still have to let them know that and still have to essentially apply for whatever position that's available. But that's a great question. And yeah, I'm actually working on that right now.
Yeah, I knew that most typically stayed where they were, but I didn't know if it was kind of an understood thing or if you still had to apply or
Yeah.
not.
I think you have preference, definitely, if you want to stay, but it's definitely not mandatory.
Druvi asked if you've ever had a case which was strange and it took you a while to figure out what was going on.
Oh yeah, all the time. Medicine is such a gray field. It's not black and white. And when I say that, I mean like it's so many different things that could be going on at once. Like just because someone comes in and they're having chest pain doesn't mean that the heart is the problem for the chest pain. There are so many different things that can cause chest pain. So you have to go through what we call a differential diagnosis, where you think about all the things that can cause whatever the patient is complaining of, and you have to kind of rule those things in or out with different tests or different imaging modalities, and through history as well, like talking to the patient, getting a history to kind of like feel like what's the quality, when did it start, what helps it, what doesn't help it, things of that nature. So I think the part of being a cardiologist that I like is basically being a detective. Got to kind of figure this out, figure things out. And there are some times where you're not 100% sure. You have an idea, but you're not 100% sure.
Gotcha. Carla asked if you were open to mentoring or if we could contact you with mentoring questions.
Yeah, definitely. I'm definitely open to answer questions. I love answering questions. I love helping. So, yeah, definitely.
Do you have like a preferable
Yeah, I
way to
can.
contact you?
Yeah. No, I prefer email. I think that's the best way. So I can leave that, and we can disseminate that somehow.
Okay, sure. If you want to put it in the chat, or you could send it to whoever contacted you for today's webinar and they could put it out. So whichever. Let's see. Emanuela asked if you felt like you're always learning, and do you go home and feel that you've learned something new in terms of technology too?
Yes, medicine is a very up to date field where there's always something new, something's always changing. The medicine that we practice now was not the medicine they were practicing 20 years ago, or even 10 years ago, even 5 years ago. It's always changing. So I always feel like I'm learning continuously. And technology wise, like a lot of the things that we use, like the things that we use in the cath lab, or our echocardiograms or the imaging modalities that we use, a lot of those things are constantly being updated. So you have to kind of be, at least tech friendly to be able to operate those machines. So I think I'm always learning, from a medical standpoint and from a technological standpoint as well.
Jasmine asked, how do you cope with 80-hour weeks as a resident fellow? So how do you cope with all of that learning?
Yeah. Honestly, I think it's very important that you prioritize your mental health, I'd say. So when I'm not at work, I'm definitely doing things that I enjoy doing. I am doing things that I find enjoyable. So whether that's spending time with my family, whether that's going to work out, whether that's going to get my hair cut, anything like that. I definitely say do that. And it's important, like I said, to have that support system, that village, because it's those times when, you're not at work where, you may feel down and they're right there to pick you up, or to do all those things that you may enjoy doing, whether that's playing sports, whether that's going to the mall, going shopping, or me, I love to travel. So anytime that I had time off, I probably was in another city or, trying to get out the country or something like that.
Got it. Um, George asked, how did you know you wanted to get an MD rather than the research route? And are you okay if that's the question that we end on, just so we wrap it up kind of soon?
Yes, that's perfectly fine. I For me, I always want, like, I'm a people person. I'm very social. I love talking to people, and I felt that by getting my MD, that was more of that fit me more as a person, and actually more of what my goals were. Research is very valuable, and I think it's very much needed. For me, however, I felt though I had a bigger impact to make if I was a more clinical person, meaning that I saw patients. And you could do both. You could get MD, PhD, and you could do half your time doing research, half your time seeing patients. But you just have to be passionate about it. And whatever you're passionate about, that's what you should do. Not do something because you feel like you have to or because someone else told you to do it. Really look deep into yourself and figure out, okay, what am I passionate about? And for me, I'm passionate about talking to people, helping people, and treating disease. So that's something that I really like and I'm really invested in. And that is the route that I decided to take because that was the best route for me.
Awesome. So first of all, thank you so much, Dr. Hackler. This was so insightful, and everybody is saying so in the chat, and we all really enjoyed listening. I put the link for the Google form in the chat, so if you want a certificate for shadowing hours for today, go fill that out. It should take you like a minute max, and then we'll have those certificates sent out within a week. Aside from that, I don't have anything else, Dr. Hackler. Just thank you, and thank you everybody for coming out on a Friday night and listening.
Well, thank you again for having me. I'm going to leave my email in the chat here for anyone who would like to get in contact with me or have any more questions. I'll be happy to answer them, or any questions that we weren't able to answer here, I can answer them at a later time. Okay.